Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Lineberger Cancer Network. Thank you so much for being here today. It's May 11th, 2022, and I hope that you're here for our patient-centered care lecture. So hopefully you're in the right place. We have a great presenter today. We're going to go over a few odds and ends and then we'll get started. Just a reminder, if you need any technical support at all, please give us a call, 919-445-1000. You can also email us, unclcn@unc.edu. We'll get back with you right away and do everything we can to make sure that this works for you. However, if you have problems with the internet, etc. today, we will be recording today's presentation and it will be available for credit as a self-paced online presentation in about a month. So know that that's the case as well. Let me go ahead and jump right in here, let you know that we will be using Poll Everywhere today. This is a great way for you to interact with our presenter, share responses to questions that you'll be asked, and then at the end, you'll be able to use Poll Everywhere to ask questions as well. 3 different ways you can use it. You can go to pollev.com, enter the letters UNCLCN, and then you'll be able to see the activities pop up. That's in any browser, on any phone or other device, and you'll be able to respond to those. You can also join by text. You can text the letters UNCLCN to the number 22333. You'll get a response back, and then you can go ahead and see that you've joined and respond with the letters that correspond to the answers. Finally, you can join with the app, and there's an app both for Android and for iPhone. You can download that for free, put in the letters UNCLCN, and off you go. I do have one little complication, and this is if you're a regular attendee with our lectures, this is new. This is something that just popped up yesterday. We're not sure why, and I apologize. We've tried to fix it, and we haven't been able to find exactly the reason that Poll Everywhere is doing this. But when you first join, it's going to prompt you to put in your name to introduce yourself. Now, this is anonymous. You don't have to do this. So just go ahead to skip and click on skip, and then you'll be able to go on and do everything in Poll Everywhere just as you have in the past. So just because it asks you for your name, you don't need to put that in there. Completely anonymous. Just click skip as is shown here in this slide, and then on you go to the rest of Poll Everywhere. All right. I know that a lot of you, in fact, most of you are probably here hoping to get credit for today's presentation. That is great. What you'll need to do is you can go ahead and make sure that you're using Zoom and seeing all the components of Zoom, the slides, etc. You can't be in audio-only mode with Zoom. You need to actually be able to see the presenter and the slides. Or you can be at a designated site, and I see we have a couple of sites on today, so you can be at a site with a site coordinator and do that. I will say that as more and more folks are getting back together in the same rooms, if you're at a place where you would like to do that, please contact us and let us know, because we'd be happy to set things up so that you can be at a site with others, have a site coordinator who takes information about your attendance and maybe have lunch at these events, etc. So do let us know if you have questions about that. A couple of things that will keep you from getting credit if you're just watching on the stream and not through Zoom, or if you're, as I mentioned, using audio only on the phone, we can't give you credit for that. You do need to attend 50 minutes or more today, fill out an evaluation and select the certificate you want, and you need to do all of that within the next 7 days, please. All right. We have multiple series in addition to patient-centered care, which is second Wednesdays at noon. We have our advanced practice provider series, and that's 4 to 5 on third Wednesdays. Our research to practice series that normally is fourth Wednesdays, 12 to 1. I believe we are skipping this month, but we've got a great presentation lined up for next month. And then our SICEP, our Southeastern American Indian Cancer Health Equity Partnership, and that's first Wednesdays, February, May, and November at noon. So lots of different opportunities, all free, all with various types of continuing education credit. So today we are excited to bring you Allison Beam, MPAP, PAC, the vital role of primary care providers in breast cancer survivorship care. And I will say that Allison is a physician assistant working for the UNC Breast Cancer Group with Dr. Lisa Carey. Prior to joining the UNC oncology team, she worked as a provider in a local health department for nearly 8 years, specializing in women's and children's health. Allison is also adjunct faculty in the physician assistant program at Campbell University. She has a particular interest in providing equitable health care to patients from underserved communities and improving health literacy. Allison, welcome. Thank you so much for being here today.
Thank you so much for having me. I'm excited to be here.
Well, we are looking forward to all that you're going to teach us today. What's something that you can tell us about you outside of the professional information that we just learned about?
Well, my husband and I have 2 dogs that are our favorite things in the world. We have a boxer named Ava and a Morkie named Angus.
Nice, nice. And hope they've been able to keep you all good company during the pandemic.
Absolutely.
I know that our 2, Lily and Ruby, have been been a big part of our support network. Well, let's go ahead and go on, and this is just a mock-up of this poll everywhere question, but this is the question, your first question for the audience. In your current practice, how confident are you in providing comprehensive care for your patients with a history of breast cancer, including managing long-term side effects of cancer treatment and assessing for recurrence? And so for our audience, you can put A, very confident, B, somewhat confident, C, not at all confident, or D and A. And just a reminder, if you're being asked for your name, just hit that skip button. These are all anonymous. You don't need to do that. If you want to put in a goofy name, you can do that too. All right, and our disclosures, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no financial relationships with commercial interests as defined by the ACCME. Greensboro Area Health Education Center is an approved provider of nursing continuing professional development for the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Allison Beam, MP, AP, PAC, has no relevant financial relationships with commercial interests as defined by the ACCME. And here is that first poll everywhere question. Wow, and I am impressed that so many folks have already jumped in and answered that. Of course, there's no right answer or wrong answer on this one. Allison, any comments at all?
I really like the variety of answers we got. That's what I was hoping to see. And I hope at the end of this, we have more in the A and B categories.
There you go. There you go. All right. Well, the vital role of primary care providers in breast cancer survivorship with Allison Beam. I'll leave it to you, Allison.
All right, thank you. Thank you again, everyone, for joining us during this lunchtime talk. So as Tim was saying in my introduction, I've been a PA for almost 9 years now, and I spent the majority of my career working at the Harnett County Health Department, so it's a rural health department here in North Carolina, doing mostly primary care women's health before I made the transition to UNC to breast oncology. So I feel like I kind of have a unique perspective on what primary care providers really need to know, and also how we can expand our role for caring for our patients with a history of breast cancer. So we're going to jump into another question just to keep you on your toes. So according to the American Cancer Society, 1 in blank women will develop breast cancer during their lifetime. Wow, you guys are fast with the answering. Good. Give everyone a chance to answer. Great. So very good. It looks like a majority of you guys know that the answer is, unfortunately, 1 in 8 women will develop breast cancer during their lifetime. So again, 1 in 8 women are going to develop breast cancer during their lifetime, and that's from recent data from the American Cancer Society. But as we know, we've gotten really good with screening and treatment, and so we're also going to have a lot of survivors in that category, with about 3.8 million breast cancer survivors in the U.S. alone being estimated currently. So as you know, the medical field as a whole has a big shortage of providers of all primary care and specialty fields, but certainly oncology is one of the most underserved or underpopulated groups right now. You can read the data below. I pulled this from several sources, just showing the number of physicians and advanced practice providers practicing in oncology in the U.S. and North Carolina versus how many primary care providers we have in these same groups. And I'm not trying to make the argument that we have too many primary care providers. I know there's a shortage there as well, but there are significantly more than there are oncologists. ASCO, in their most recent report in 2021, the state of the oncology workforce, also estimated that 21.1% of current practicing oncologists are nearing retirement age. And we're only graduating about 570 so fellows each year. So this gap is just going to broaden. So who are we talking about when we talk about breast cancer survivors? Breast cancer survivors are anyone living through, with, and beyond breast cancer. There are some variations in different groups as far as the definition, but according to the National Cancer Institute, a patient is considered a cancer survivor from the date of diagnosis until the end of their life for whatever reason. So why is the survivorship care an important part of primary care? Well, if 1 in 8 women are going to have breast cancer, and that doesn't even include the men who get breast cancer as well, which we know that's rare, but it is still a very real occurrence, then more than likely you already have or are going to have many breast cancer survivors in your care. A life after cancer diagnosis comes with its own unique challenges that are very different and extend far beyond what patients go through during those active treatment years. And as we all know, cancer does not occur in a vacuum. Patients often have many other health conditions and comorbidities that can affect or be affected by their cancer therapies. So this is something that we really have to pay close attention to. Survivors see their oncology team very often during their initial diagnosis and treatment. And so that relationship is built. But before this ever came into play, they many times already have a very close relationship with their PCPs, whom they trust thoroughly. And so a lot of times the PCP is a very important role and ends up being a big advocate for this patient during their cancer treatment because of that history that's already there. So some of the key points we're going to go through in this talk are just three major things I wanted to highlight. So number one is going to be the do's and don'ts of screening. Next, we'll talk about the long-term effects of cancer therapy, specifically breast cancer therapy. If we talked about the long-term effects of all sorts of cancer therapies, this will be a multiple series talk. So today we're just focused on breast cancer. And then we're also going to talk about the survivorship care plan, which may or may not be something you're already familiar with. So we'll start with screening for breast cancer. So I'm sure you're familiar already with the general screening recommendations for patients who do not have a personal history of breast cancer, but just to sort of review those quickly, patients with an average risk who are asymptomatic who are between the ages of 25 and 40 should have a clinical breast exam every 1 to 3 years. and as needed based on symptoms. And then also should be educated on breast awareness. So what is their normal baseline and how to do breast exams themselves. Asymptomatic women who are over 40 or above should have a clinical exam annually as well as a screening mammogram annually. And then patients who have a lifetime risk of greater than 20%. So this can be defined by a strong family history or genetic testing. Patients who have had a history of prior thoracic radiation. We see this often with children or young adults who had leukemia or Hodgkin's lymphoma or things like that as when they were younger. Patients with a history of LCIS or atypical ductal hyperplasia who also have a higher risk of cancer, of developing breast cancer, we recommend that they get an annual MRI in addition to an annual mammogram. These are usually done on a every 6-month basis, alternating. And anyone with a history of breast cancer in their family should be counseled on doing self-breast exams as well. Now, patients with a personal history of breast cancer, this can change the screening recommendations for sure. So for the first 5 years following diagnosis, we recommend a clinical breast exam every 3 to 6 months, and then annually, and of course as indicated. This can be done by, usually these patients are coming in for treatment with the medical oncology team, the radiation oncology team, and surgical team. And so usually these breast exams done this frequently in the first 5 years are handled by the oncology clinic. But that's not to say that patients who have this history of a recent diagnosis of breast cancer who are coming into a primary care or OB/GYN clinic should not have a breast exam because we just assume someone else is doing it. There's not too much examining that can happen in these first 5 years because that's when the risk of recurrence is the highest, as we'll talk about later. Annual mammogram is recommended for any patient with a personal history of breast cancer who still has breast tissue, i.e. they have not had complete mastectomies or mastectomy on one side, they would still need a mammogram on the opposite breast. We want these mammograms to be done at least 6 months after the completion of radiation therapy. And they're typically diagnostic mammograms, no longer screening mammograms for the first 5 years, and then can usually return to routine screening mammograms if their breast tissue has been stable, benign, and the radiation doctors are usually very good, the radiology doctors, are usually very good about kind of giving the recommendations for when the patient is truly able to go back to screening. Routine imaging of a reconstructed breast is not typically recommended other than MRIs usually are recommended every 3 to 5 years depending on the implant, just for surveillance of the implant. But again, if a patient has had mastectomy with no reconstruction, then no routine imaging is required. However, we still do chest wall and axillary exams. So genetic screening for breast cancer, this is something that's been very well talked about and more commercially available in the last several years. Typically, we think of the BRCA genes, but there are many other genes that can make patients more likely to develop breast cancer as well. Genetic screening is not something that's typically just indicated for every person to see if they have a risk, although with some of these commercial tests, people are able to do that and access them themselves. But as far as being ordered from a clinical perspective, these are things that are usually ordered on patients who are diagnosed at an age less than 45 or diagnosed older than 45 with at least one close blood relative with breast, prostate, ovarian, or pancreatic cancer in their family. Patients diagnosed at over 50 with 3 blood relatives with breast or prostate cancer, this is also a recommendation. And then anyone with lobular breast cancer with a history of gastric cancer. Triple negative breast cancer at any age, this is a recommendation for genetic testing. Certainly any male who has breast cancer or a blood relative who is male. Those patients could have testing as well. And then anyone of Ashkenazi Jewish descent. So when we're looking for recurrence for these patients, there are 3 types of recurrence. There's local, which means cancer returns in this original breast that it was found in before, or chest area. Regional is when the cancer comes back near the original tumor in the lymph nodes of the axilla of that side or in the collarbone. So more still on the same side, but farther beyond just the breast tissue itself. And then distant recurrence is certainly, we probably think of metastatic disease first. Breast cancer typically goes to the lungs, bones, brain, liver. But it can also go to places such as the contralateral breast, and that would be considered distant recurrence. So who is at risk for recurrence? So unfortunately, anyone with a history of breast cancer can have a recurrence. There certainly are some factors that give you a higher risk of recurrence, but it can happen at any time and to anyone who's had the history. Women who develop breast cancer before age 35 are much more likely to have a second breast cancer just because of the age of diagnosis. Cancer stage and grade that is of a higher stage and grade is more likely to recur. Larger tumor size and lymph node involvement as well is part of this. And then certain aggressive types of cancer, such as inflammatory or triple negative breast cancers, can be harder to treat initially and therefore have a higher risk of recurrence. So there are some tools that we use in oncology that I'm not going to go into a lot of detail with, but just wanted to mention them. There are things like the Oncotype DX, Prosigna. There are tools we can use such as Breast Cancer Index or the Predict UK prediction models that we can use to sort of help us guide treatment. So not every patient who has breast cancer will need chemotherapy. Some of these tests, for instance, can say that they test the tumor itself and can say there would not be a lot of added benefit with chemotherapy. We can just treat this patient with endocrine therapy. And these tests can also help us guide how long we need to use that endocrine therapy, if the standard 5 years is okay, or if we need to go to 10. So these are not things that you would be ordering or interpreting through primary care, but they're helpful to just know what these tests are and why we use them, and maybe answer some questions of why some patients need chemo for one kind of breast cancer and a patient with a very similar kind didn't. So ways we can reduce the risk of recurrence are, again, most local recurrences occur within 5 years of initial diagnosis and treatment. Patients with hormone receptor, so ER and PR, estrogen and progesterone receptor positive cancers, can go on endocrine therapy such as aromatase inhibitors or tamoxifen for 5 to 10 years in combination with ovarian suppression if they're premenopausal, and this can significantly reduce breast cancer recurrence. Radiation following a lumpectomy or following a mastectomy, if there's axillary involvement, can help reduce the risk. And interestingly, something I'm not a surgeon, so I didn't want to get too detailed on this, but certainly something that I think is helpful and is a very common misconception is that there's no significant survival data in a lumpectomy or partial mastectomy versus a total mastectomy. So just to look through some signs of recurrence, local recurrence, obviously the one we would think of first would be a new breast lump or swelling, any skin changes of that breast, nipple changes or discharge, new swelling or pulling at the lumpectomy scar, and things like that are all things we would look for. Regionally, we can see swollen lymph nodes in the axilla or clavicle, chest pain, sometimes difficulty swallowing or hoarseness of voice, depending on if there are mediastinal lymph node involvement. Distant recurrence can be a little harder to detect and realize that that's what's going on. So people can develop things like a chronic dry cough, abdominal pain, new onset headaches, extreme fatigue or weakness, lack of appetite and weight loss, new persistent bone pain, and new otherwise unexplained hypercalcemia, anemia, or elevated LFTs. So if these things are presenting in patient with any history of breast cancer, a workup should start. So, and that can start with things like a mammogram and a breast ultrasound if this is a local concern, or regional or distant recurrence can initially be evaluated using a CT of the appropriate area as well. Also, things like swelling in arms, legs, DVTs that are in a patient that doesn't really have a good reason to have coagulability, hypercoagulability, that's something to look for as well. So what we don't recommend doing for your non-metastatic patients that just have a history of breast cancer, or we don't usually use tumor markers just to monitor for recurrence of disease. They are more useful as a trending tool over time in treatment effect for metastatic patients, but are not very diagnostic for just cancer recurrence. So, and can cause a lot of unnecessary stress because they can become elevated for a variety of non-cancer related reasons. Sometimes we'll see that patients with history of estrogen receptor positive breast cancer, people are checking their estrogen levels, and that's not really recommended as well. It's just another way that's not very good to monitor their breast cancer. Everyone's going to have estrogen in their blood, so it's not very helpful. CBC or CMP, certainly these are very useful tools and probably things that you're ordering in a primary care clinic on your patients, and that's fine, but we just don't recommend them as something to monitor recurrence of breast cancer. And then routine CT, PET scans, bone scans, liver ultrasounds in patients who are asymptomatic. As I'm sure you all know, if you've ordered a chest CT looking for one thing, you'll inadvertently find many other things. And in a patient with a history of cancer, that's something that's going to have to be worked up and causes a lot of unnecessary stress and financial burden and healthcare system burden. So they're not recommended that we just do PET scans on people just because they had a history of cancer unless they have some symptoms that warrant that. Okay, so our next question, all of the following can result in an increased risk for breast cancer recurrence except A, age greater than 35 at diagnosis, triple negative breast cancer, lymph node involvement, or a T3 tumor, which means greater than 5 centimeters. So all of these result in an increased risk for recurrence except which of the following? Good. Very good. So yes, women who were diagnosed before age 35 are at a higher risk for recurrence. So, and everyone knew triple negative was bad. I'm glad to see that. Okay, so now into the next part of our talk, the long-term effects of breast cancer treatment. So adjuvant endocrine therapy is used for patients with hormone receptor positive. So that means estrogen or progesterone receptor positive breast cancer. And the way that we usually treat those are sort of two families of drugs. The first are our selective estrogen receptor modifiers. Mostly what we use in that family is tamoxifen. There are some others as well, but tamoxifen is sort of the most well-known. And then the aromatase inhibitors, which are letrozole, anastrozole, and exemestane. Letrozole, I'm sure you know, can also be used as a fertility drug as well. So these patients will typically be on at least 5 years of therapy, and some may benefit from up to 10 years of therapy, depending on certain risk factors. So we usually use tamoxifen or the SERMs in women who are premenopausal because it does not require ovarian suppression to go along with it. but it can also certainly be used in women who are postmenopausal as well. These medications are suppressing estrogen, so they're essentially creating menopause, correct? So the side effects are going to be very similar to menopausal side effects. And as you can imagine, a woman who has not yet gone through menopause, these may be more severe for her. So the side effects of our tamoxifen is hot flashes, vaginal dryness, thinning hair, can cause amenorrhea, but not always. There is an increased risk of DVT, similar to with birth control pills, and an increased risk of endometrial cancer or endometrial hyperplasia, and then cataracts. So for patients who are on tamoxifen, we recommend annual GYN screenings and eye exams, no matter what their age is. Aromatase inhibitors can be used, typically this is what we use in our postmenopausal women, but can also be used in premenopausal women in conjunction with ovarian suppression, which could either be Lupron injections or having their ovaries removed completely. The side effects of this are hot flashes, vaginal dryness. The biggest one we hear with this is arthralgias or myalgias, and decreased bone mineral density. So women taking aromatase inhibitors should have a DEXA bone density scan every 1 to 2 years while on therapy. Hot flashes are probably the most bothersome of side effects for either of these families, and we know that's a result of the estrogen suppression. They occur in women who have already gone through menopause before starting therapy, and certainly in women who have not gone through menopause. For obvious reasons, we do not recommend hormone replacement therapy when the whole point of giving this is to decrease the estrogen. This is a really great table that lists some of the effective treatments for hot flashes. Venlafaxine seems to have the best data for this. Gabapentin and some SSRIs can also be used. As you'll see though, paroxetine and fluoxetine can decrease the efficacy of tamoxifen, so we generally try to avoid those in patients also on tamoxifen. Vitamin E, 800 units, does have some efficacy. It's about 50% of the women who show decreased hot flashes with taking vitamin E. It's fairly benign. I tell patients a lot of times that the worst it's going to do is make you have really moisturized skin and hair and not help your hot flashes. So for patients who aren't interested in going on gabapentin or an antidepressant essentially for this, that's always a good thing to try. Melatonin also has some data as well, especially with tamoxifen-related hot flashes. Acupuncture is also something that many patients report being very helpful in controlling hot flashes as well. Sexual functioning is also a very big concern of women who have, and men truly, who have undergone breast cancer treatment. Studies show that 40 to 100% of patients with a history of breast cancer experience some level of decreased sexual functioning. This can be due to hormonal changes, certainly, but also lingering fatigue or pain, body image issues, especially if they've had mastectomies or things like that, and emotional exhaustion of going through a cancer diagnosis. So ASCO recommends that a member of the patient's medical team screen for sexual functioning issues for all patients with a cancer diagnosis. This is something that patients often are embarrassed to bring up on their own, but will feel comfortable, we're more comfortable about if you as their provider bring it up. And so people may go untreated for years because we just never really brought this up. And treatment is really the underlying cause. So we can use vaginal lubricants. There's a new medication on the market, Addy, that is used for women with low libido. And then certainly sometimes just some psychosocial or sexual counseling can be helpful as well. Again, as I talked about before, vaginal dryness can be a big issue here, can lead to painful intercourse, painful exercise, and increased UTIs, as well as just discomfort. Hormone replacement therapy, again, is contraindicated for anyone with hormone receptor positive breast cancer history. The exception being low-dose topical estrogen may be considered if their symptoms are refractory to all other non-hormonal symptoms. And even for patients with triple negative breast cancer, we don't recommend just giving them hormone replacement therapy either. We recommend vaginal moisturizers 3 to 5 times per week, and lubricants with all sexual activity, and this can include coconut oil, KY, things like that. Pelvic floor therapy and laser therapy for vaginal rejuvenation can also be really helpful for patients for whom this is a really big problem. So contraception and cancer, especially as you're seeing, there are women being diagnosed much younger than 35 years old with breast cancer, and so we certainly don't want them to become pregnant during chemotherapy. So chemo does tend to cause amenorrhea, but studies show that most women less than 35 years old during their treatment will resume normal menstruation within 2 years. So again, we do not want patients to become pregnant during chemo if we can avoid that, or while on radiation or endocrine therapy, and generally within 6 months of completing immunotherapy like Keytruda as well. But we also don't want to use hormonal contraception for women with a history of hormone receptor positive cancer, and that includes the pills, the patch, the depot injection, and IUDs other than the copper IUD. So those remain contraindicated. So copper IUDs with no hormones or barrier methods are really what we really stress for these patients. Osteoporosis, again, like we talked about before with the aromatase inhibitors, this can certainly decrease bone mineral density, as well as being postmenopausal can decrease this as well. So we recommend DEXA scans every 2 years for women on these medications and women who have chemo-induced premature menopause. The treatment, usually first line, we start with vitamin D and calcium and weight-bearing exercise, and we can always add bisphosphonates as well. Tamoxifen, interestingly, is bone protective. So if patients are already diagnosed with osteopenia at the time of their breast cancer diagnosis, tamoxifen may be something that we would go to first to help build that bone mineral density back up. Peripheral neuropathy is a huge long-term effect of cancer treatment that can oftentimes be lifelong in some cases. It's a very common side effect of certain chemotherapy agents for breast cancer. This is usually our taxanes. So anyone who was on paclitaxel, Taxol, Taxotere, those sorts of, anything with tax, those can be very causative agents of neuropathy. So this can resolve or improve with the completion of chemo, but it can also be permanent. So we treat this very similarly to as we do any neuropathy. So duloxetine, gabapentin, Lyrica can also sometimes be used. Exercise, and again, acupuncture has been found to be very beneficial for many patients. Something that we recommend for patients, and recently in the last few years, is cryotherapy, which is wearing cold gloves and boots on the fingers and toes to keep the chemo from getting to the fingertips and therefore reducing the risk of the neuropathy. And also we will do dose reductions in the amount of chemotherapy if this is becoming a problem, so we can hopefully not make this a chronic condition for patients following their cancer treatment. Cardiotoxicity is something that I think is probably under-recognized, but very, very important. So according to the American College of Cardiology and the American Heart Association, patients with a history of early stage breast cancer are more likely to die of heart disease than cancer. Many of the common drugs that we use for breast cancer treatment, such as anthracyclines or doxorubicin, the red devil is the rap that it gets in the breast cancer world, or trastuzumab and any of the HER2-directed medications, and as well as radiation causing oxidative stress to the heart. These patients are monitored with an echo or a MUGA scan every 3 months while they're on the treatment, but they should continue to be monitored closely for signs of heart failure for the remainder of their life following treatment, as the damage should present years later to the heart. So we don't necessarily recommend getting an echo every 3 months for the rest of their lives, just while they're on the treatment, and then certainly have a very low threshold for adding these echoes in if these patients have any concern of heart failure developing symptoms. The selective estrogen receptor modifiers like tamoxifen can lower cholesterol but increase the risk of DVT. And aromatase inhibitors can increase cholesterol. So those, while not as detrimental to cardiac health as the chemos can be, certainly there's something to think of as well for your patients who maybe have a history of high cholesterol. Ribociclib is a CDK4/6 inhibitor that we use for patients with metastatic estrogen receptor positive breast cancer, but it can cause QTc prolongation. So definitely want to be aware of that if you're prescribing other medications that can cause QTc prolongation as well. Cognitive impairment, or chemo brain as many people refer to it, will affect up to 75% of cancer patients, and this includes problems with memory, executive functioning, processing speed, and attention. And this can happen during or after treatment of their cancer. Up to 35% of patients experience long-term cognitive declines years beyond their chemotherapy treatment. The exact mechanism of this is really unknown. It's likely very multifactorial, as many things are. Initially during treatment, a lot of this can be due to just the stress of all the things that are going on and all the things patients are trying to manage, as well as the fatigue or insomnia from treatment. Menopause and hormonal changes we know can also cause some cognitive impairment issues, so that's just adding on to what's already going on for these patients. And then there are some interesting findings about gray matter reduction during chemotherapy and just the inflammation caused by cancer itself that can be contributing to this as well. And then anxiety, depression, and fatigue, as I mentioned, can be completely ongoing. These are some of the words that I have just hear on a daily basis from patients at various stages of their cancer treatment. I often find there's a lot of PTSD especially coming into the cancer hospital, but seeking any medical care following cancer treatments can happen, as well as guilt for doing well when they know someone else who didn't do as well, self-blame, fear, all sorts of things. These patients can get very, very scan anxiety. I hear a lot with mammograms. So these are things to screen. We should really be screening all our patients for, but especially patients with a history of cancer. Lymphedema is another very prominent issue with breast cancer patients, especially depending on the type of surgery they had. So just a couple of things that can increase the risk of lymphedema is, first of all, the number of lymph nodes removed. So patients who have an axillary dissection where many lymph nodes are removed surgically certainly have a higher risk than patients who just had a sentinel lymph node biopsy, though patients who had a sentinel lymph node biopsy are certainly not immune from getting lymphedema issues as well. If even one lymph node is removed, then patients can have trouble with lymphedema. Patients with a mastectomy versus lumpectomy have a higher risk of lymphedema, as well as no reconstruction versus reconstruction. Adjuvant treatment, so treatment with chemotherapy after surgery that involves the use of a taxane, can increase the risk as well as higher BMI at the time of diagnosis. And I'm sure you've all seen lymphedema in varieties, but I just wanted to include these pictures to show how uncomfortable and detrimental this can be for patients. And this is not something that we can just typically treat with Lasix and it gets better. This requires the compression sleeves. This is a lymphedema pump the gentleman below is wearing that patients, it's very effective, but patients have to use this about an hour a day, every day, to help sort of move that fluid through and keep it from collecting in the tissue. So this can be a really debilitating side effect. So physical therapy with a lymphedema certified physical therapist, if available, is the key in getting this started early. So at some points, we start these patients as soon as they're finished with surgery and they're healed enough to begin therapy. There have been some patients, depending on the lymph node involvement of the cancer, even prior to surgery, we will go ahead and get them set up with physical therapy to help keep those arms moving. These physical therapists, especially a lymphedema certified specialist, can teach self-massage and also how to use the compression sleeves and gloves and the pneumatic pumps, as I showed in the last slide. So one thing that is very controversial within the medical community are doing blood pressures and blood draws on patients who have had lymph nodes removed. So, and even as I was preparing for this talk and trying to look through, there's no good consensus. So the best recommendation would be if a patient has had lymph nodes removed, to use the opposite arm for blood draws and blood pressure checks, if at all possible. Certainly, these precautionary measures might be unnecessary, but if you're able to use the other arm, it's always better to do that if possible. In emergency situations, or if there are just no good veins, it's not a complete contraindication, but should be avoided if you can. If you have to do a blood pressure check in an at-risk arm, you should use the manual blood pressure cuff versus one of the electric ones, if possible. Okay, I think this is our last question. So a patient whose breast cancer treatment, including which of the following drugs, puts her at a higher risk of heart failure even years after treatment completion? So A, paclitaxel, B, carboplatin, C, trastuzumab, or D, tamoxifen. So this is asking about the risk of heart failure after cancer treatment. Great. Trastuzumab, which is a HER2-directed drug. And this is the highest risk of heart failure specifically. So certainly tamoxifen can cause DVTs, and none of these are benign, but any drug that's directing the HER2 protein of breast cancer, which trastuzumab or Herceptin is the name it's more commonly known by, can be very cardiotoxic. Great. Okay, and lastly, I just wanted to introduce, or hopefully some of you are already familiar with the concept of a survivorship care plan. So I'm sure you cannot read this, but I just wanted to scan in what ASCO's breast cancer specific survivorship care plan looks like. Many oncology practices use these in various degrees to share with primary care providers and the patients, especially when they're reaching that point of being discharged from the oncology team. And what it essentially is a summary of all the things that have happened with this patient. So what age were they at diagnosis? What were their receptors? What kind of surgery did they have? Do they need mammograms, and how often? Are MRIs indicated? Is the patient on tamoxifen or an AI, or have they been and they finished it? What kind of chemotherapy, if any, did this patient get during their treatment? And what side effects does the PCP need to be monitoring for as a result of these? Other things like radiation are important and mentioned on these as well. So I know, we've all been there. You get 12 pages of notes every time your patient sees a specialist, and no one has time to read through all of those. So it's nice to have this 2.5-page summary that kind of gives you the bread and butter of what you need to know and how to use that to help take care of your patient. It's also really helpful to give to the patients themselves, because as we know, patients travel around, they move, they go from office to office and state to state, and it's really helpful for them to have this while we're waiting on the longer, more complete medical records. So at least the new PCP can sort of know this is what happened to this patient. if she starts having, a cough and ankle swelling, maybe, and she has a history of HER2 chemo, so I should probably look into this and make sure she doesn't have heart failure as well. So I had never personally received a survivorship care plan as a PCP, and many of my friends who still work in primary care were not familiar with this as well. So I do think it's something that we could we should be using better during the transition from oncology back to primary care. So again, these are the biggest components that are listed in it, as well as familial and genetic risk factors. I forgot to mention that earlier as well. Also, it provides the contact information for the primary oncologist. So if you have questions, you know easily who to reach out to and contact. And I'm aware that getting up with said oncologist may be easier said than done, but my hope is that as the survivorship care plans are used more appropriately, there will be more bidirectional communication between primary care and oncologists as well. So I just wanted to finish by saying the good physician treats the disease and the great physician treats the patient who has the disease. So we're all in this together, where it's not oncology and primary care. We're in two different silos. We're all here with the collective goal of taking care of our patient. And so anything that we can do to help each other take care of the patient, I think is amazing. And I really appreciate everyone for attending this. And having that same interest. So I think we're ready for questions.
Absolutely. Allison, this has been just wonderful. Thank you so much. You've shared an incredible amount of information here, very succinctly. We do now open this up to questions. Just a reminder, the best way to share those questions is through Poll Everywhere, and all of our audience members should now see that. I do see that one came in on the chat. Actually, we had a couple come in on the chat, so I can go ahead and share those with you. One of them was, where is the best place to put the SCP into the patient's chart for the PCPs to be able to view? Is there a way to let the PCP know that the SCP is there for reference? Great question.
That is a great question. So with Epic, which is what we use at UNC, so that's what I'm most familiar with. With Epic, it is pre-populated for us to fill out, and then we send it electronically or by fax the way we do all patient records to the PCP. But I do think that's a great point. If there was a tab that gave that in the history, I think that's a really great idea, and definitely something I would like to look into. So I'm glad that you agree. So thanks for that question.
And I'll add that it, as a question that I was wondering about, what's the ideal relationship that you see between the cancer care team and the primary care physician as the patient moves to her or his healthcare environment that may be far away from where that person was treated for cancer, for breast cancer? How is that relationship best established and maintained?
Sure. So I think as we get more electronic medical records, it's definitely easier to share communication, but also easier for communications to get lost, unfortunately, in the pile of them. Ideally, the survivorship care plan should be a living document that's updated throughout the course of a patient's treatment, not just something we say, here you go, after 5 years. And also making more of a bidirectional communication would be really helpful. If this patient's cholesterol is getting up really high and you're changing medications, then we need to know about that too, so we don't prescribe something that could interfere.
Yeah, absolutely. All right, more questions coming in. This is great. Keep them coming. So this next one, is it automatic or standard that you share prognosis at the beginning of diagnosis, or only if the patient asks for those prediction tools?
Great question. So there are lots of caveats and requirements for the prediction tools that I didn't want to get into just for the purpose of this talk. Just to sort of give you an overview, so the prediction tools are usually used for only hormone receptor positive cancers that are a small to medium tumor size with less than 3 nodes involved typically. So patients outside of that criteria would not be offered a prediction tool at all. And the prediction tool would just really be used. It's more telling you, is there a benefit to having chemotherapy or just going to endocrine therapy? So again, just for those certain group of patients. But yeah, so it's done before they would start chemotherapy. It helps make the decision if we're going to chemo or not.
Great. Thank you so much. Is it necessary for an early stage breast cancer survivor with no evidence of disease, but with BRCA2 plus mutation, to have an appointment with an oncologist each year if it's been over 10 years since diagnosis and treatment? My oncologist has retired, and I am comfortable with the PCP doing the checkups.
That is a great question. Thank you so much for attending. I love to have a perspective from a breast cancer survivor too. And so I think you've essentially answered your own question. And what I would say is that if you're comfortable with your PCP doing your checkups, and especially being 10 years since diagnosis, then there's really no need for you to continue to see an oncologist. I joke, we always have the bell when you finish chemo. We need a bell for when you finish having to see your oncologist as well. Usually it varies per patient, but average is 5 to 10 years after therapy, depending on the type of cancer and things like that. But especially 10 years out, if you're comfortable going to your PCP, I definitely think that's warranted.
Right. And another question, this one came in on the chat earlier. Before I ask it, I'm going to put in a shameless plug, because just a few weeks back, we had a wonderful presentation on peripheral neuropathy and treatment, including cryotherapy and pressure treatment, with Dr. Luprinzi, who's from Mayo, who's one of the top experts in the world on this. So I encourage folks who want to learn more about that to possibly look at that lecture as well. The question was, does neuropathy occur early, or can it be late effect?
Great question too. Yes, so it usually occurs during is when it presents, is while they're getting treatment. Occasionally we can see it present later. There's a lot of theory that is usually just an exacerbation of some neuropathy that's also being caused by something else, such as diabetes. Mostly if it's cancer treatment related, it's at least starts during their treatment and then just continues on and on.
Great. Thank you, Allison. You mentioned annual gynecological exams for patients who had taken tamoxifen. Does this include annual pap smears?
Does not necessarily include annual pap smears. As you know, pap smears are on the 3 to 5 year screening. It's mostly just for a pelvic exam, and if there's any concern of endometrial hyperplasia, so we're really more of a bimanual exam, feeling the uterus, then we would recommend an ultrasound, because that's the side effect of tamoxifen we're looking for.
All right, thank you. And we had a couple of questions. Well, we can maybe combine, let's see, about acupuncture. One individual had asked, where would I how would I go about finding an acupuncturist? Where would I look for an acupuncturist? And I would assume somebody reputable with, specifically with breast cancer patients. And then with acupuncture, what is the consensus on the precautions involving the risk of lymphedema and infection?
Great questions. So most integrative medicine, most larger cancer centers have an integrative medicine team that usually consists of someone who's trained in acupuncture, and I would definitely recommend someone who has specific training in acupuncture for cancer patients, because they're going to know, first of all, exactly what they're targeting side effect wise for cancer patients, and also be really cognizant of the risk of infection. When patients are in chemo, we don't don't recommend a lot of invasive type procedures. My understanding is that acupuncture needles are very shallow, so don't cause a whole lot of infection risk. But lymphedema is a great question too. So I just recommend going to someone who really has training for cancer acupuncture uses specifically.
Great, thank you so much. And we are nearing the 1 o'clock time period. So we'll take this one question, last question, and then we'll go ahead and move to wrapping up. Should DEXA scans every 2 years continue after AI use is discontinued?
We usually get one immediately following the within 2 years of discontinuing, and then as you would for any other patient, get your DEXA scan. You can resume sort of normal recommendations at that point.
Great, great. Thank you to our audience for all of these great questions.
Great
and
question.
Allison, thank you for answering them. My gosh. I mentioned Dr. Liprinzi with the peripheral neuropathy. I should also mention, because you talked about the chemo brain, and we've had some wonderful lectures that I would encourage our audience to look at. Dr. Nakamura and others talking about the chemo brain, and I know that I've learned a lot from those.
And Dr. Jensen's cardiotoxicity.
Absolutely.
Oh,
thank
really
you.
good.
Thank you.
Yeah.
Good one. Good one. So I want to say thank you to the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to say thank you to our team for making each and every one of these possible. Mary King, John Powell, Jason Paler, Veneranda Obore, Oliver Marth, and Andrew Dodgson, and we could not make this happen without all of them. So thank you. We do have, and this is actually another nice segue, our next week at 4 p.m., our APP lecture is on sex and AYAs with cancer. Mitigating and managing sexual dysfunction. So that's one of the topics, not AYA specific, but the topic that you had brought up in some detail earlier. So I encourage those who are interested to consider signing up and attending that APP lecture. Then we have our next patient-centered care lecture on June 8th, cancer genetics and genetic testing. It's not all in the family with Dr. Berg and Kate Foreman. And then our next APP lecture, laboratory workup for transfusion reactions with Dr. Evans. So I hope that you'll consider signing up for any of those that are of interest. As always, we have more lectures that you can take on your own schedule, our self-paced online courses. We have, I think, over 30 of them that are now available on any given day with varying types of free continuing education credit. New one with Dr. Woriaks and our SciCep partnership, a new APP with Melissa Holt, another one with Dr. Jensen. That's that cardiotoxicity cancer therapy. So anyone can sign up, take that, receive free credit for that. And then early detection of colorectal cancer. Don't get left behind. 45 is the new 50, another one of our PCC lectures. So lots to choose from. Be on the lookout for our next survey, which will be coming out. And that's an opportunity that we make available annually for our audience members to tell us what you want to hear about, who you want to hear about it from. So that will be coming out shortly. Please be on the lookout for that. As always, you can find a ton of information about our programs at unclcn.org, on Facebook, on Twitter, on YouTube, on ViewMedi. If you have any questions, email us, unclcn@unc.edu, or call us 919-445-1000. Let me just check.